مرحبا بكم أخواننا جميعا في هذه المحاضرة titled as Treatment Strategies for Osteoporosis. In this lecture we will have a general review, just a general review of the treatment strategies that we have with respect to managing this complex disease of osteoporosis. We will touch base with anabolics and how they work, and so we will review some of the literature of this new class. We will of course touch base with the anti-resorptives and visit some of old questions and with the new concepts. And then we will talk about the strategies that we have, which is monotherapy versus sequential versus combination therapy. These strategies has been largely adopted by the IOF Society and the Worldwide Society, and we continue to adopt new approaches as the evidence builds up. The first questions that we need to address is, does anti-resorptive reduce bone formation? And to answer this question, we need to understand the concept of the crosstalk or the coupling between the osteoclast and the osteoblast. When the osteoclast stimulated, it also stimulates the osteoblast via multiple cytokines. The other way around is true. If the osteoblast is stimulated for whatever reason, the acerbican, it will stimulate the osteoclast via the rank ligand. With that in mind, and if you look at this cartoon here, when stimulated the osteoclast, it will stimulate the osteoblast, as I just mentioned. However, when you suppress the class with anti-resorptives, you will inevitably also suppress, to a lesser degree nevertheless, the blast formation. So the answer is yes, the anti-resorptive, they do reduce the bone formation, but they reduce bone remodeling in much potent way. On the other hand, or on the flip side of the coin, does anabolic increase bone resorption? Now, back to the same slide, or to the same concept of class, blast, crosstalks. When you introduce anabolic to the bones, then clearly you are stimulating osteoblast, and by doing so, it will stimulate through rank ligand the osteoclast formation, but of course to a lesser extent. So when you stop your anabolic, the anti-resorptive turnover will continue, and you may well lose the benefit you have gained. So the answer to that question is yet again is yes, and anabolics does increase bone resorption. So just to have a glance on the features or characteristics of the functions of anabolics and anti-resorptive drugs. Anabolic agent, they do improve bone microarchitect, they increase bone formation, this is how they work, and they also increase bone resorption to a less extent. And by doing so, by reducing bone resorption, they actually reduce secondary mineralization phase, and therefore increase resorption cavities. Now, the other way around, with respect to the anti-resorptive, they do not improve the microarchitect, but they maintain it. They prevent it from getting worse. They reduce bone formation, as I was just showing you, and they reduce bone resorption to a greater extent, and therefore they increase secondary mineralization phase, and also they reduce resorption cavities. So these are the features of each class, and it's clearly almost a mirror feature of the other class. Now, we'll touch base with the two main anabolic agent that's been approved by the FDA, teriparatide and romosozumab, that we use here in Australia. Now, normally, I'll take you through the mechanism of action of teriparatide. Normally, PTH, or our endogenous PTH, which usually gets secreted every 3 to 4 minutes on pulses, they tend to stimulate, the PTH tend to stimulate the osteoblast to secrete rank ligand. So this is the transcriptional pathway that the PTH goes through within the osteoblast. And then the rank ligand, of course, will stimulate osteoclast to mature and start doing its job in bone resorption. However, if you use exogenous PTH in high doses, you'll actually reduce the pulsatility of the endogenous PTH, and subsequently you will stimulate the osteoblast to mature and start doing its job as anabolic cells, and they will have less effect, or the effect on the rank ligand stimulation will be diminished. So this concept was introduced in 1932 by a Canadian endocrinologist who suggested that if PTH is administered in very small doses, once daily dose, it will stimulate the osteoblast. But if it's introduced in pulses, like we normally have in our system, in our biological system, then you will actually induce a class formation via rank ligand. This is a study was published in 2009 that showed the different effect of the anti-resorptive, and we have talked about this in our bone biology lectures in the past, and it shows that the anti-resorptive clearly showing this zigzag line here on the bones, while the anabolic, they introduce a smooth line indicative that this bone was formed is actually a new bone. However, looking at the PTH, and you look at the teriparatide group, the newly formed bone, highlighted here by the double tetracycline labeling, actually went quite far long distance than they anticipated, and what you normally have in the control. Now, that was a very interesting findings. Again, this showed that about 30% of the bone formed with the teriparatide group was actually a newly modeled bone, and this is the area here. 30% bone formation, that's quite significant. Now, this is a YouTube
is a pro-remodeling anabolic agent that removes older or fatigued bone and adds more bone than was present before treatment. While Forteo stimulates the coupled process of bone remodeling, it preferentially increases the number and activity of osteoblasts, causing new bone to overfill existing resorption sites. New bone also forms on adjacent surfaces without prior resorption, contributing to the positive bone balance.
If you hear this speaker, then on this YouTube animation, it just shows that the bone formed with teriparatide is actually overfilled the resorption cavity. It works on the resorption cavities, not on the quiescent bone, and this is important to understand. And working on the resorbed cavity, it actually overfill them, and it goes over beyond the edges. It spills over beyond the edges, and that's the attributed to its anabolic net positive balance. Now, we have spoken about the findings of the scientist Frost, who many years back found that there's about 3% of bone formed that actually exceed the area that's resorbed. So there's about 3% extra bone formed during the resorption remodeling cycle, and this is his overflow hypothesis, which is clearly approved with the teriparatide trials. So he was yet again right. Now, with that in mind, then we all should agree that teriparatide is a remodeling drug, or remodeling directed. It's a remodeling directed anabolic agent. It works only on the resorbed side. It fills the resorption cavities and spill over to the margins. And therefore, it is, as Prof. Seaman suggested, it's an okay anabolic drug. لا بأس فيه ولكنه بها قوة. ليش مو قوي كثير؟ لأنه it only works on the resorption cavities. It doesn't work on the quiescent bone. And we have mentioned before we talk about romosozumab, before قبل أن نتكلم عن romosozumab, the other agent, we have talked about the remodeling rate is about 10%, involves 10% of our skeleton per year, and therefore the teriparatide will work on this 10% and give you 30% extra benefit. ولكن if you can find a drug like romosozumab, which works on the remodeling and quiescent sides, then you will involve more area of the skeleton to benefit from anabolics. And the way it works, and it does do that, and the way it do that by inhibiting the inhibitor of the Wnt signaling pathway. The Wnt signaling pathway is famous for its effect on the blast cell to mature and starts its role as anabolic cells through these receptors, the LRP5 and 6, and its co-frizzled receptors. However, the sclerostin inhibits this compound and therefore inhibit the blast cell formation, or activation, I should say. Anti-sclerostin, that is monoclonal antibodies against the sclerostin, and this is what the romosozumab does. It prevents the sclerostin from inhibiting these receptors, and therefore they continue to activate the blast cells. The FRAME study is the pioneer study that looked into the effectiveness of the romosozumab against control, and clearly it was very effective in the lumbar spine, less effective but nevertheless significantly still on the hips, and not so much on the radius. Now, once you stop the romosozumab in green, the bone density gain will be lost again and will drop down to the baseline, pre-treatment baseline, and that applies to hip as well and the radial. However, if you continue with the denosumab, then you will maintain this benefit and even slightly more gain in the vertebrae. So the anabolic effect of romosozumab is actually non-sustainable, but it's nevertheless significant. Now, if you look at the bone turnover markers, after 12 months, they drop, or towards the end of the year, they start dropping down. This is the P1NP and the C-telopeptide. The C-telopeptide start to go up, and the P1NP will start to drop down until it reaches the pre-treatment baseline after almost 12 months. And Prof. Ebling believe this is, he thinks that this is related most likely to osteoblast depletion, and therefore that has a limitation on the duration of use of romosozumab. Now, why did we use denosumab after Romo? And I think it's pharmaceutical bias. They're both sponsored by the same pharmaceutical companies, but nevertheless, it did work. Anabolics mainly. So, in summary, with regard to romosozumab, its anabolic effect mainly lasts for 12 months, and it does have some anti-resorptive thereafter. They found there's actually increased cardiovascular risk and stroke by about 2%. And this is a real phenomena. Well, they didn't find it in the frame study, but they found it in other in the arch and structure studies. And the reason they couldn't find this alarming signal in the frame study, because the patient population they studied in that study, in the trial, was actually of younger population. So it is prudent to make sure that the patient's cardiovascular risk factors are well controlled in terms of blood pressure, cholesterol. They also need to have a cardiogram as a baseline to rule out any silent ischemia before you start romosozumab. Those who have any acute vascular event within 12 months are contraindicated for Romo. Again, patient selection, whom we decide to treat with romosozumab. Anyone with severe osteoporosis that is known to have high sclerostin levels, and it has to be severe osteoporosis. This is a very expensive drug, and we should only save it for those who we shouldn't be really recommending this treatment for mild to moderate osteoporosis. Low risk, someone who had a low cardiovascular risk, and we shouldn't go beyond 12 months because it will lose its benefit. It will lose its benefit and efficacy. And then after that, you can change it over to more affordable anti-resorptive to maintain the benefit you gained. Otherwise, you may well lose it. This is a schematic cartoon that shows that the teriparatide is a remodeling based, and it works on the resorption cavities predominantly. So 70% of function of the BMD gain is by filling up the resorption cavity. There's an extra 30% going over the edges here. Romosozumab, on the other hand, it actually works on the quiescent bones. Okay, this one has no resorption cavity, and it's the main impact of the 70% of the bone gained with romosozumab is actually in the quiescent bones, while 30% of the bone gained with teriparatide works in the quiescent bones. This is another study that looked into, it's actually four arms RCT, and they looked into romosozumab versus teriparatide and alendronate and with respect to BMD. And clearly, the romosozumab here in green has scored much better than the teriparatide, particularly because it actually works, as I said, in the quiescent spine, which is about 90% of our spine at any point in time. So, and if you look at it, particularly the delta between BMD gained with the Romo in comparison to that with the teriparatide is more pronounced, of course, at the hips, because the teriparatide it does really poorly at the hip spine, and it was definitely better the teriparatide in orange, and of course the alendronate in blue. The alendronate as an anti-resorptive scored lower the other drugs on the lumbar, and it scored slightly better actually than the teriparatide at the hip. Now, so in summary, the anabolic we need to reserve these drugs for the very high risk group. Someone had recurrent fractures or have recent fracture or multiple fractures with a BMD lower than -3 and a low bone turnover. If you give it to high bone turnover osteoporosis, then you may well make it worse, because مثل ما شفنا بداية المحاضرة إنه الانabolics they increase osteoclast function as well as the osteoblast. So you really want to have the bone turnover markers under 500 nanogram per liter. Now, all the anabolics has a short offset. They lose its benefit once they stop the drug, both of them, romosozumab and teriparatide. They are cost prohibitive, they are expensive, they're not really cheap drugs, and they are coupling agent. They stimulate the osteoclast as well as the osteoblast, but not to the same degree. Now, which anabolic to use? Romosozumab, I think predominantly for hip osteoporosis, someone who had a raised baseline PTH, someone with CKD, for example, or normal calcemic hyperparathyroidism. You cannot use teriparatide if you have a baseline PTH. Any osteoporosis that's known to have raised sclerostin, including CKD, and diabetic patient, potentially steroid patient as well, but there's no strong evidence for that as yet. A dynamic bone disease of the with renal failure or with dialysis patient, I think there's a good chance, but at the moment the eGFR cutoff for Romo is 30 ml per minute. Now, teriparatide, on the other hand, you can use it with someone who has severe osteoporosis, however have a high CV risk, atypical fractures, because romosozumab is not approved for those group as yet. Someone with non-union, again, romosozumab is not approved for that as yet. And osteonecrosis of the jaw, yes, you can use teriparatide, and it works really well. Now, we'll move on to treatment strategies, monotherapy, combination, or sequential. Monotherapy, you only have anti-resorptive that you can use as monotherapy. There is no role for anabolic as monotherapy because they lose their benefit once you stop the treatment. Okay, so that's something to have to bear in mind. خليت لكم هذا السلايد حتى تعرفون إنه most of the anti-resorptive agents we have, except raloxifene, they work in the lumbar predominantly, the spine, and to variable degrees on the hip. So it's important to know when you facing a case with predominantly hip osteoporosis, which agent to choose, and at least you need to avoid raloxifene in this group because they won't benefit from it. Now, denosumab is has been introduced the last few years, and it was a breakthrough in many ways. And this is the study from the Freedom and the Freedom Extension trial that clearly showed a continuous improvement in bone mineral density over 10 years span with the subsequent continuous reduction in the vertebral fractures. However, the question was raised, why would an anti-resorptive cause the increase in bone mineral density to continue for close to 10, well, for almost 10, or for a total of 10 years? And this is a study that was actually, this result in this study was ignored, but then they revisited the slides. They noticed actually the yellow line, which represent newly bone formed, was identified in the endocortex of the animal where they tried the denosumab. So the question was risen: is denosumab has a dual anti-resorptive and an anabolic agent? Well, when you look at the profile, the PTH with denosumab goes up, and the CTX and P1NP they goes down. This is exactly the mirror image, the opposite of teriparatide. Teriparatide being an anabolic agent, what it does, it reduces PTH, increases P1NP and CTX. So if it has the mirror image of the biomarkers of anabolics, how does it improve the bone density? And this is a study that compared denosumab to the bone turnover markers in the denosumab arm, which is in the green, as opposed to the alendronate in the blue line. And what you could, well, I could to appreciate is right at the end, after 3 months of the denosumab injection, the CTX start to climb up, and same thing applies for the P1NP, particularly in the second year, it shoots up. So there is a window of opportunity to build up bone when this rebound phenomena happens. So there is no direct anabolic effect, but perhaps it's a permissive role through these windows of rebound in the bone turnover markers. Now, again, it's the same, it's a short offset effect. Once you stop the treatment, the CTX goes up the roof and the P1NP goes up to baseline. The bone mineral density drops down to baseline within a couple of years' time, or even less than a year time. As a matter of fact, the study has showed if there is delay, and there were quite a few case reports when there is delay, about 6 weeks in the injection for whatever reason, unintentional delay, the patient reported multiple vertebral fractures. So when you commit your patient for this drug, you need to ensure they have it right on time. The reason why there is a loss in benefit, because it's like the anabolics, doesn't stick to the bones, it circulates in the blood, it does not sustain benefit. So this is what I mentioned, that the vertebral fractures significantly increase once you are off treatment, 6-7 times more, and it actually usually happens, and even multiple fractures, not just one fracture, multiple fractures, 4 times more. It's actually, if you look at the relative risk increase, is about 100%. 10-fold, or the odds ratio is 10-fold higher of sustaining multiple vertebral fractures. For the reason I just mentioned. We'll move on to the zoledronic acid. Now, we used to give it for 3 years. This is the Z6 trial, which showed ongoing benefit with the orange arm with respect to BMD in 6 years' time, and a significant drop in the BMD if you were to stop the drugs in 3 years' time. There was 50%, almost 50% risk of morphometric silent vertebral fractures in the group that stopped the drug after 3 years. Now, this is an old study. We know now that we should continue Zoli or anti-resorptive once you start treatment for osteoporotic patient. You should continue for life. It's a chronic, non-curable disease. And what we do is actually we tend to space out the drug. Instead of giving it every year, you can wait for the C-telepeptide to start going up, and then you can introduce another injection, perhaps once every 2 or 3 years. So, and that what the author concluded, that someone with a high-risk fractures, they need to continue annual infusions, or at least once every 2 years. Now, sequentials versus combination therapy. This is the new strategy that we are adopting for treatment. So we start with sequential, and the options we have for sequential is either you start with anti-resorptive and then you move into anabolic agent, or into another anti-resorptive, or you start with anti-resorptive and then you move into anabolic, or you start with anabolic and you move back to anti-resorptive. So these are the 3 options we have, and I'll take you through it one by one. So anti-resorptive to another anti-resorptive. This is a study again that showed the impact of switching over from alendronate to denosumab. Now there's an improvement, which is clearly a stronger anti-resorptive drug, and there's a significant improvement in the BMD, both in lumbar spine and in the denosumab, favoring denosumab treatment. Now, we touch base on the C-telepeptide and P1NP, and they clearly scored better profile with the denosumab, indicating that this is a stronger drug. How about changing from alendronate to zoledronic acid? And this is there is actually a non-inferiority study that was suggestive that they both just as good. And even with the C-telepeptide or the bone turnover markers, they slightly have a better profile with the zoledronic acid. So we don't think there's actually much. We don't think there is a significant difference between benefit you will get between Zoli and alendronate. However, there is adherence issues. In this particular study, patient much preferred the once yearly injection, so they don't have to stick to this weekly tablet, which could cause severe heartburn. And even the enteric coated tablet, they still have GI side effects and esophagitis and requiring PPI long term. And I can tell you from my experience with my patient, they actually tend to be it did disturb their quality of life. Zoledronic acid against denosumab, if you were to switch over, the BMD was better in the denosumab as we expected. Both of these arms in this RCT, they were exposed to alendronate before they randomized them into Zoli or denosumab, so they were not drug naive, and that, in my view, can affect the result in some way. This is a study here, unpublished yet, and it showed that if you start with denosumab, once you stop with denosumab, you actually lose the benefit. But if you were to continue denosumab in the blue line, but if you were to switch over from denosumab into a more affordable and cheaper drug such as alendronate, it does maintain the benefit and prevent the BMD from dropping down. And same thing for the bone turnover markers. They remain low once you continue on alendronate. So it is okay to change over from one bisphosphonate, one anti-resorptive to the other, with some studies suggesting that the switching over to denosumab, they do a little bit better off. Now, this particular study has showed limitation. They actually, there's about 15 or 16% of the group had lost 30%, they lost 3% of the BMD gain, but this loss was particularly in the group that has the highest BMD gain. So we think this is probably regression to the mean phenomena. It was done using different multicentral trial, but it's a proof of concept, and it did prove that alendronate works well after denosumab. So how about if we move to the other option, and that is starting with anti-resorptive and moving into anabolic, or switching over to anabolic. And this is a structural study that essentially showed you start with alendronate, and then you switch over to romosozumab and the blue line, or teriparatide, and you could see, I hope you appreciate, in the total hip, there was loss in bone mineral density by about 1% in the teriparatide group. That was not the case with the romosozumab. In the lumbar spine, there was continuous gain in the BMD. So that's one thing we have to bear in mind. How about moving from denosumab, not alendronate, denosumab to teriparatide, with patients who were on alendronate, and then they changed them over to denosumab versus teriparatide. Denosumab in the red line, and the teriparatide in the blue line, and you could see that with the hip, particularly, the BMD dropped down significantly, and the femoral neck in the teriparatide. So it just shows again that moving from anti-resorptive to anabolic might not be a good idea, particularly with teriparatide. So, last option we have is anabolic towards anti-resorptive. You start with anabolic and then you switch over to anti-resorptive. And this is a study, it's color coded, and I'll show and take you with it. And why did we essentially thought of combination therapy? Because we know, as I showed you from the initial slides, that once you start with model bone, you're actually stimulating the osteoclast simultaneously, and therefore when you stop the drugs, the osteoclasts continue to resorb and you lose the benefit you've gained. Now in this study, they showed that when you start with teriparatide, anabolic, you switch over to denosumab, there is a gain of benefit in the BMD, and this actually was done with the volumetric using HRPQ-CT. Now, when you start with denosumab and you switch over to teriparatide, particularly the trabecular bone and the whole bones, they start losing the bone density and they drop below the baseline. So you actually will be at a loss. You will lose bone density if you start with denosumab and you switch over to teriparatide. Now, the combination arm in the green, they actually showed better than either drug and than the other strategies. Moving to the last study here, which I think is the most intriguing result, and shows if you were to start with denosumab in red line and you switch over at this point to teriparatide, what happens is you lose the benefit initially at the lumbar and you lose it a lot on the hip and the femoral neck. So that's a bad news. If you start with teriparatide and you switch over to denosumab in the blue line, you continue to gain the benefit. You continue to increase the BMD all the way through the 40 years of the trial. Again, in the hip area, the teriparatide didn't do that well. There was even no change, hardly any benefit in the hip, and then start benefiting, increasing BMD in the hip once you introduce denosumab. The combination arm was better than any other combination in green. So you started with the combination in the lumbar, continue to gain BMD, and at the hip particularly, this scored the highest score in the whole groups of patients. So in summary, anti-resorptive to anabolic might not be a good idea. Anti-resorptive to another anti-resorptive is actually okay, and it does do the job, particularly if you start with an expensive drug such as denosumab and you switch over to alendronate to maintain the benefit. Anabolic to anti-resorptive, that's actually a pretty good strategy, and combination strategy, which is yet to be endorsed by many societies worldwide, but I'm sure it will in the foreseeable future. It's probably a good combination too. In summary, monotherapy, combination, sequential. It's at the end of the day which agent you use for which patient, which combination for which patient, and which sequence of drugs, which sequential therapy strategies you use for which patient. So patient selection is of paramount.